She was a known glaucoma. She was a known glaucoma suspect who had had no prior treatment and had a history of hypertension, but no significant family history. On examination, her visual acuities were 6.6 in both eyes, and she had slightly thinned central corneal thicknesses of 500 in the right and 522 in the left. Her intraocular pressures were 16 and 18, and on gonioscopy, she had open angles bilaterally with just some iris processes visible medially. Her cup to disc ratios were 0.5 and no. Her Humphrey visual fields did show some mild inferior field changes in both eyes, which corresponded to the nerve fiber layer changes. But at this point, she was just monitored as a glaucoma suspect every 6 monthly for the next couple of years. She was diagnosed 2 years later with glaucomatous optic neuropathy in both eyes, and her pressures had crept up to 20 bilaterally, and she had further lost more nerve fiber layer in the left with the associated field loss down below. And she was commenced on Xalatan eye drops. She had a good response, and her pressure dropped to about 12 at her subsequent visits. So the right eye was also started on treatment soon after. This is a graph of her IOP trend over time, showing when she first presented to the clinic and was first started on the topical treatment. The right eye is the blue line and the left eye is the red line. We can see in about 2006 that her left eye pressure started to rise slowly, and she had further field loss. So it was actually advised that the patient had surgery, but she was very hesitant. So she actually sought a second opinion in private, and SLT was performed instead. She did have a good response to the laser. As we can see, the IOP was quite stable over the next 8 to 9 years, but during this time, she was actually trialed on many different types of eye drops to keep her pressures under control. And by 2015, 2016, she was on maximum medical therapy in both eyes. So these are serial HRT scans of her right disc, where we can see during that period from 2006 to 2016 that the nerve was fairly stable. However, in about 2018, we can see some nerve fiber layer change, particularly superiorly on the disc. And this again was a time where it was urged that the patient have surgery due to her glaucoma progression. But again, she still was not keen, so another round of SLT was performed in both eyes this time. However, unfortunately, we can see that she continued to progress until she had quite a significant change. She finally had surgery and right Zen implant or Zen trabeculectomy. The left eye similarly shows a stable nerve fiber layer over that period. Changes. Again, she had SLT in 2018 and then a third round in 2019, but has continued to slowly lose more nerve fiber layer. And this is an OCT of her nerve fiber layer thickness. This is our earliest scan that we have of this patient in 2016. It just demonstrates that she has quite thin fiber layer in both eyes. Serials, unlike demonstrated on her HRT already. This in both eyes shows that in the left, she slowly lost her inferior visual field with a failed appointment, and in the right, similarly slow loss of her visual field. Actually, at this point in time, this point reduction in her field. However, this was associated with a right superior hemiangle retinal vein occlusion. So she had the vascular event. So her treatment up to this point had included topical drops. She had tried, and this was mainly due to the side effects she experienced. She was complaining of stinging, redness, blepharitis, dermatitis, and some drowsiness. T treatments in her left eye, and just one single treatment in her right eye, and finally had surgery in the right eye with a Zen and mitomycin C at slit lamp photographs taken at her most recent visit when Prof and I saw her in the clinic a couple of weeks ago. And these are mainly to demonstrate the differences. So the right eye is now just on timolol, as she's had the Zen a couple of years ago, and the left eye on Ganfort and Simbrinza. And we can see how the left eye is more affected by dermatitis and blepharitis, affecting the eyelids and periorbital area, and the right eye has much less affected skin. These are slit beam photos of the right eye. We can see the Zen in the anterior chamber in the superior nasal quadrant, and on the right-hand side is the diffuse phleb. And these are gonioscopy, where the Zen entrance site is through the trabecular meshwork, as the formation of peripheral anterior synechiae. And if you remember at the beginning, when she first presented, she had wide open angles with no evidence of any angle closure at the beginning of her follow-up. So we can see all the PAS, particularly through this area in the right eye. And in the left eye, there's even more areas of PAS. We can see that the synechiae is sort of blocking the angle, and this is the eye that has had more SLT treatment. And these are the color fundus photos of both eyes. So on the left-hand side is her right disc, which is fairly cut, and we can see the superior collateral vessels as a result of her previous hemiretinal vein occlusion. And on the left, on the left disc, again, a fairly inferior temporal aspect of the disc. And it's an appointment where I've marked her recent events, where she had the vascular occlusion SLT, and then she had a Zen 2 years ago, and most recently a right cataract. We have an angle light formation. Her left eye is continuing to progress, and her glaucoma is worsening, as evidenced by the disc changes on the HRT scans, as well as the further field loss. And her rising intraocular pressure, as well as the new disc hemorrhage that we saw on the previous slide. This is also putting the patient at risk of another vascular event in her left eye with her advanced glaucoma, especially as she's had this occurrence in her fellow eye. And if we can control the pressure and reduce it, we'll also subsequently reduce her risk of having another retinal vein occlusion. So what is next for this patient? What should we do? Her left eye is still progressing, and now she's on maximum medical therapy. So we have laser or surgery left. And if you answered no to laser, you would be correct. We can see that this hasn't had a sustained effect with all the PAS in her angles, so we are left with surgery. Potentially, she could have a Zen. However, a consideration is they tend to have a higher failure rate in angle closure glaucoma subtypes. However, the Zen seems to have worked in her right eye, so this is definitely a possibility, or she may proceed with a trabeculectomy. And so to summarize, the challenges to management in this patient's care have been her compliance to treatment, particularly because of the side effects of topical drops that she suffered from, as well as her expectations about surgery. So her main concerns were surgical complications, as she had heard from colleagues or friends who had glaucoma surgery that they had either had failed surgeries or complications. Unfortunately, she had suffered a right hemivein occlusion, and her glaucoma was definitely a risk factor for this event. It has a odds ratio of 4.6. And initially, early on in her treatment, she had a good response to SLT, but we can see how this had a reduced effect on her IOP over time, and repeat treatments led to PAS. This is an uncommon sequelae of SLT. However, it can be related to technique, which has a higher risk of formation with more posteriorly positioned burns, and as well as having an increased number of treatments. And finally, she's had a surgery in her right eye, which seems to have stabilized her glaucoma in the right, and so is likely headed in a similar direction in her left eye.
Mark, we've got time for a couple of questions if anyone would like to ask any questions.
Yeah. Is this patient is a Caucasian or is it like an Asian?
Southeast Asian, I think, of Chinese origin. Mm-hmm. Is that correct?
Yes,
Jessica?
that's right.
Yeah, that's right.
Yeah. Is it common like the inflammation reaction like in the case that you have performed, because you know that in our hospital we don't have SLT, so we never perform that. Is it quite common, the complication with the technique here?
I haven't seen publications calculating the proportion, but I do see it regularly. So it's definitely not uncommon. This lady apparently had iris processes when she was first seen in 2012 with wide open angle. So, part of me wonders whether the iris processes were a risk factor for development of synechia with the laser. But as Jessica says, I think it has to do with the technique as well, if the spots are posterior. I have seen it in patients who've got an element of angle closure where the iris is already close to the meshwork, and I suspect it's the inflammation somehow draws the iris up.
Is it
yeah, I was going to say, I don't think you're missing too much by not having SLT laser.
Is it related with the race prof, or it is like quite common in everybody?
I've seen it in Caucasians as well as, so I don't think it's restricted to Southeast Asians or Chinese ancestry. But again, as far as I'm aware, no one's published on that. Well, I haven't gone hunting for through the literature, but so I can't really say for certain whether there's a racial predilection or not.
Thank you.
We thought this lady had pretty much a full house. She had disc rim hemorrhage in one eye, sequelae of hemivein occlusion in the other eye, fairly advanced glaucoma, secondary angle closure from laser. Yeah, so, and also drug allergies drug reactions, if you like, in one eye. So she poor thing.
Or is she has another like systemic condition?
No other systemic conditions, but almost certainly related to the glaucoma. As Jessica said, there's about a 5 times. In fact, glaucoma or ocular hypertension are the single greatest risk factors for vein occlusion.
Yeah.
Sorry. Oh, not at all. Thank you for answering all the tough questions.
Virna, shall we move on to you? I'm looking forward to hearing your take on surgical and medical therapy in glaucoma. And it might be just worth explaining that Virna probably, and Tria and others probably do more glaucoma drainage device surgeries than certainly anyone in Australia, and probably most people in the world. So we've got one of the real experts here. So Virna, please take it away, and we're looking forward to hearing from you.
Thank you, Prof. Thank you. I'm sorry if I'm not preparing quite well with this presentation, because you know that last week I just arrived from Greece, so hopefully it will satisfy everyone, and I hope we could discuss more. So if there is something that maybe you want to add or you want to ask, please don't hesitate to do that. I will have I change a bit with the title, so I think I have like medical and surgical therapy in glaucoma. As we know that everybody know that glaucoma is a chronic progressive disease, and it is lifelong management is needed to preserve the visual function. It is our goal to have this patient to preserve the visual function, hopefully until they die. The treatment modalities in glaucoma, we know that medical treatment, laser, and surgery. In this topic, I will only focus on medical and then surgery. And for the surgery, we know that there is several types of surgery. We have filtering surgery, we have minimally invasive glaucoma surgery, and also we have implant surgery. And for the management of the glaucoma, it is based on the pathogenesis of the disease. So the type of the glaucoma will require a different treatment, I think. It is related, like if it is, whether it is angle closure or whether it is open angle, or if we know the causes like secondary glaucoma, then we will treat the causes. So the management of glaucoma mostly based on the pathogenesis of the disease. So understanding the pathogenesis will help to choose the correct management for the patients. And clinical understanding, especially signs and symptoms, is needed to considering the type of glaucoma. Sometimes we miss, as I could see, because I'm in the clinical in the teaching hospital. So I know sometimes that my students will forget or sometimes miss with the a sign of pseudoexfoliation glaucoma, or sometimes post-nurse closement, something like that. But if we try to understand the signs and symptoms, then they will know whether it is like a not open angle, but actually like pseudoexfoliation glaucoma, or maybe it is pigmentary glaucoma, because we could see from the gonioscopy examination. And the management of glaucoma is mainly considering by the type of glaucoma, like if whether it is childhood angle closure, as I mentioned previously, open angle secondary glaucoma. So appropriate and accurate management will help to halt the disease progression. Another issue in managing glaucoma patient is the quality of life. The quality of life will be influenced by several factors. Like we know that glaucoma is a chronic disease, and also patients and family perspectives. If we deal with a patient with a good understanding with glaucoma, usually it is easier to have them taking the medication, or maybe discussing if we have to do glaucoma. Usually they will hesitate and a bit maybe like rejecting what we have or what we have given to them as a therapy. And also the daily activities will influence the quality of life, age and gender, and also health and economic profile. I don't know whether it will affect the gender in the Australian, but in Indonesia it does, because sometimes between women and men in our country, I could see that, like example for the cataract surgery, mostly is men. It is women is like less. I think the number of population is more women, but one of the result of the study, cataract surgery is mostly men. So it is like something that we should know more about the tradition maybe. And the type of glaucoma and also the cost and benefit and quality of life, this will like make us choosing whether we will have surgery first or we have to give the medical therapy for the patient. I will start with medical therapy. And for the medical therapy, there is several things that we should consider, like the effectiveness and also how to do give our application of the medication. Because as you know that now we are expanding not only with topical medication, but now there is like a implant, like slowly slow release drugs that put in the eye or in the subconjunctival area. It is like being explored whether we could use that as in the retina disease. So we will know in the next future maybe. But now maybe mostly like the topical medication. And also pharmacokinetics, like mode of actions and also the duration of the medication, the side effects. We know that everybody will have quite different things with the medication, and also the contraindications. Some medication may be not available for the patient due to the systemic condition, like patient with asthma that we can't give a beta blocker, and also other things like that we should consider. And also we know that patient have a compliance. Although the patient understand about the disease and also about the medical therapy, not everyone is eager to have like long-term medication. And this one, I mean the compliance will affect the quality of life of the patient, and also whether we could preserve the visual function by the medication. This is like a summary, but actually I will describe later on about quite several type of medication we have, like prostaglandin analog. Maybe all of you have known about this. There is like a prostaglandin analog that we know. In Indonesia, Prof, we only have three types. Latanopros. Oh no, only two. Latanopros and taflopros. We don't have trafopros and we don't have bimatopros actually at the moment. Because you know that in our country we have like a regulation that maybe not easy to for everyone or for every company to have a drug selling in Indonesia. As we know, prostaglandin analog have ability about decreasing the IOP about 25 to 35%, but we have local side effects for this medication. You could see from the literature, mostly related with the hyperemia, and also some patient has like periocular changes, periorbital fat thinning, and also some people maybe have like hyperpigmentation around the eye, something like that. For the systemic, it is rarely, but I found some patient of mine have like hypertension even. But I don't know, because the patient told she told me that every time she has a latanopros and she checked the blood pressure and she told me that it is increased. So I don't know whether it is side effect or no, because it is not rarely stated. And for beta blocker, as we know that in Indonesia, we have timolol 0.25 and to 0.5 for the non-selective, and for the selective betaxolol we have also. And then the IOP reduction for beta blocker is about 20 to 25%, but we know that beta blocker has systemic side effects related with the respiratory systems and also the cardiovascular systems. So we have to be very careful when we want to give this medication. I have one patient that after I give the beta blocker, not me, but from other hospital, he told me that after he got the glaucoma medication, he quite frequently has his asthmatic reaction. So I asked about the medication that he has, then he told me that he got a beta blocker. So then I asked him to stop the beta blocker and change with other medication. And then the other thing is the carbonic anhydrase inhibitors. In Indonesia, we only have the oral acetazolamide. Actually, there is one safe for the patient with renal function disease, which is metzolamide, but in Indonesia we don't have that. So we only have acetazolamide. And for the topical, we have brinzolamide. We don't have dorzolamide. And the capability of the acetazolamide is about 30 to 40% for the oral. And usually we use this medication for the acute condition, or if we can't control the IOP, especially we found that we have quite nasty cases with refractory glaucoma. So prior the surgery, usually we use this medication. And also for the topical, we have like brinzolamide with the ability to decrease the IOP is about 20%. But mostly I could see that the patient has a side effect is mostly local, like stinging, burning, and also discomfort. So most of my patients complain with this local in the eye, local side effect in the eye. And then for alpha-2 agonists, unfortunately in Indonesia we don't have the single therapy like brimonidine or apracronidine. We have a combine between the brimonidine and brinzolamide. So it is so that we can't choose for giving only this one medication, but we should give like a combined medication, brimonidine and brinzolamide. But as we know that for brimonidine, especially for the children, we can't give it because it will cause drowsiness. But actually, one of my colleagues have shared her experience with the brimonidine, that she has an adult with drowsiness after she gave the brimonidine medication. Also, I have this case with my patient as well. Actually, she is already like about 32 years old, but every time she got the combination of brimonidine and brinzolamide, she will have like a very sleepy and even very lethargic. So after she put the medication, she will sleep like about 3 hours. So it is quite rare maybe, but I've got that in my patient. But for the alpha-2 agonists, we know that sometimes we could have an allergic reaction. So we have to see the condition of the patient, especially in the local allergic conjunctivitis. And then for parasympatomimetic medication, actually it is now it is very rare to use this. Maybe we only use this for the angle closure glaucoma, or in some cases with pigmentary glaucoma prior the laser sometimes, but it is very rare. Because sometimes pilocarpine is not making the patient feeling uncomfortable, because it is like make the pupil miosis, and then it is sometimes make the patient have a myopic shift, and then also like because it is miosis, you know that due to the decrease of visual field, it is like if the pupil is become miosis, so the patient become more blur the vision. It is actually the ability of the myoticum is quite good, about 20 to 25% to decrease the IOP. And this is actually the one of the newest one. I think, is it already in Australia, Prof? The ROC kinase inhibitors like netarsudil or ripasudil, because we don't have that in Indonesia. For ROC kinase inhibitors with the ability to decrease the IOP about 20 to 25%. From the literature or from the research that they compare with the other medication, especially I think the studies about with the beta blocker with the timolol, it is quite the same. About the ability is about 20 to 25%. This one is the proposed for the mechanism of glaucoma medication that actually being on research maybe in some of them. So we know that in glaucoma, research about medication is quite expanding. When I heard in the latest conference, I could see that several type of medication has been built. But I don't know whether if we will have a genetic therapy like in retina diseases, because you know that in some kind of retina diseases now they have a gene therapy for the patient, but for the glaucoma, I think we don't have that yet. But we don't know, in the near future, maybe sometimes we will have that, maybe, because we know that sometimes of glaucoma is related with the genetic disease. This is the guidelines for giving the medication for our patient. I think mostly we'll choose the prostaglandin analog as the first therapy, because the frequency of the drugs is only 1 time a day, and also the ability to decrease the IOP. So it is like a first line therapy. But in our country, sometimes we choose prostaglandin analog, sometimes we choose beta blocker. It depends on the condition of the patient, because prostaglandin analog is quite expensive compared with the beta blocker. So sometimes if the condition is tolerable for the patient or the IOP is not very high, we will start with the beta blocker, and then afterward we will see whether we have to adding another medication. But as you see, if we have first medication, then we will see whether it is effective or not, and we evaluate the patient about a month. And if the IOP is achieve the target pressure, then we don't have to change the medication. Then we will follow up the patient with the visual field and also the optic nerve head condition, and then we do the follow up for this patient. This is actually for like the guidelines for some places, I think. And this is the compliance that have the study about the compliance for the patient. It's actually done in Singapore, and it is in Asian population, published in Archive of Ophthalmology, but it's quite a long study, I think. From the patient that has a medication for about 1 year, the one that's still persistent is about only 22.5%. But 77.5% is non-persistent. So we could see that most of our patient is non-compliant. In the 3 years persistence rate, it is even decreasing to 11.5%. So it is like half of the 1 year. Compared with the non-persistent, we could see it is increased to 88.5%. So we could see that the problem is related with the compliance of the patient if we give a long-term glaucoma medication. In patient that we give the medication, we have to do the routine follow-up. So we have to check the IOP routinely to know whether it is in our control or not. Then we have to evaluate the structure of the optic nerve head, recording the progression, as like Dr. Jessica has shown us, that they follow up the patient and see whether there is progression, and then trying to give to the patient if the condition is worsening, so we have to do something with the eye. And also for the function of the optic nerve head, we have to evaluate the visual field every 6 months. And sometimes I also check the patient with contrast sensitivity or even color vision for to the patient. We should evaluate every aspects in the routine follow-up, and then if it is progress, we have to see whether the IOP is in control or not. I mean in the clinic. If IOP is not well controlled, so if we see in our record that the patient is not having a good IOP, then we should ask whether the patient has a good compliance or not. Most of my patients actually, Prof, is not non-compliance. Sometimes because they can't afford the medication, or like we have a government insurance actually, but the government insurance sometimes not given the patient for whole month therapy. So if we give the patient medication, sometimes it is only for about 2 weeks or 3 weeks. So there will be left 1 week without medication, whether the patient should buy the drugs or the patient should wait with another visit. So it happens. So it's quite a big problem for us about the compliance. So it is like quite answering the question why we have quite high surgery treatment problem. And then if the patient is it is not well controlled with and she has or he has a good compliance, then we should consider whether we have to add or substitute the medication, depend on the effectiveness. If it is effective, I mean like working with the range of its effectivity, like about for like prostacyclin analog about 30%, so we should add medication. But if it is not achieve the effectiveness, like if we are giving a prostacyclin analog, but it only achieve like 10% of effectivity, so sometimes I will change the medication. And then also if the IOP, if it is progression, but the IOP achieve the target pressure in the clinic, so we should know, or we should consider whether there is a diurnal variation in this patient. Maybe this patient has like a different IOP in different time. So we should ask the patient to come in the different time. Like if we check it in the morning, or we check it in the afternoon, or we check a bit later in the afternoon, maybe we will see whether there is a different IOP or not. So it is better if we check the IOP, we put the hours when we do the examination. And also the peak IOP. Sometimes the patient has a peak IOP that over the one that we predict. Especially in glaucoma patients, sometimes peak IOP will be more than 9. Even I read in the literature about pigmentary glaucoma or pseudoexfoliation, they could have a difference range of until about 30 millimeter mercury or even 40 millimeter mercury. So we have to see whether there is a peak IOP in this patient in not in the office hour. If we have this, then we should set up a new target pressure, and then we maybe have to add another medication. Now we proceed with surgical therapy. Oh, one thing I haven't mentioned, I think, for the medication is the problem with ocular surface problems. Actually, it's already mentioned a bit in Dr. Jessica presentation, that sometimes if we have long-term glaucoma medication, we will face patient with ocular surface disease, and it is quite common. Even in my hospital, I have seen patient with the ocular surface problem. Although not every patient, but I could see in some patients they have a ocular surface problem after they use the glaucoma medication for sometimes. And now I will proceed with the surgical therapy. As I mentioned previously, that for the surgery in glaucoma, we should consider some condition. First, if we failed with a maximal medical tolerable therapy, because not every patient we could give many glaucoma medication, maybe only like 2 or 3, or maybe even only 1 because of the systemic condition or maybe the allergic reaction or something like that. So it is different in every individual. And also health condition to avoidable intervention. And we have a patient with poor or very poor patient's compliance. So usually if in this patient like this, I will suggest this patient to have a surgery first, if or primary surgery if the patient is very poor or very poor even for the compliance. And also if a patient with if it is very far from health services, to follow up and to how to assess the progression, as you know that in our country is an island, so sometimes it is not easy to have patient have a routine follow up like every 6 months, even it is sometimes it is difficult. So if I ask the patient to come 6 months, maybe he or she will come about a year later, some things like that. So in condition like that, we should consider other management for this patient. And also the affordability. For surgery in glaucoma, if there is like several types. Iridectomy, maybe it's already placed by laser, but I know in some place in our country we still do the surgical iridectomy. And also for some cases, like for uveitic glaucoma with iris bombay, usually I will choose surgical iridectomy because I have quite not a good experience. I mean, experience with my patient with uveitic glaucoma. After I did the laser, usually it will close in just in a weeks or even in days. So usually I will just choose the iridectomy, surgical iridectomy. It is long lasting. And also then the other type is filtering surgery. We have like penetrating filtering surgery. I think full thickness is not a choice now, right, Prof? It is like a quite old procedure, say a procedure. But I have done this when I don't have any other when I don't have any other choices. Like I couldn't put the implant in the eye because of the condition of the eye, and also because of the trabeculectomy has already failed. So then I have done, I think I maybe like about 2 or 3 cases with say procedure, but maybe it is about a few years ago. And also partial thickness, that it is quite common in our country, trabeculectomy, which is maybe in Australia it will be SEN procedure now, right, Prof? And also in some country they change to pressure flow, I think. Other than SEN, they use the pressure flow to change the trabeculectomy. We don't have that. Maybe we should develop something like SEN or pressure flow in order we could have another mix in our country. And non-penetrating filtering surgery like deep sclerectomy or viscocanalostomy, I think it is not popular in our country, but I know in several countries in Europe, they still did the deep sclerectomy and viscocanalostomy. And also implant surgery, we have several types of implant like Barfeld, Ahmed, and also in Australia, I know there is a Morteno. And in our country, I mean in my hospital, I've done a VGI mostly now. It is easy to have and it is quite good for me. And also minimally invasive glaucoma surgery. Actually, it is very, very, I mean, the variety is very wide for the minimally invasive glaucoma surgery, but later on we will discuss about this. But most common in our country is trabeculectomy. Also, maybe it is quite different in Australia. I think I will skip the video, Prof. Okay, and then the mix, like subconjunctival infiltration with express. I think express is not very popular now. And also in focus shunt, and I think the pressure flow is now have a quite demand, I think, because it is more like a stent. Is it like for subconjunctival filtration? And some have enhanced enhance trabecular outflow like trabectome or GAT, I-stent, hydrus, or and also for enhancing suprachoroidal flow like CIPES, and for subconjunctival filtration it's the same between the SAN and pressure flow, I think. But in our country, maybe type industry who has this like pressure flow. When I met them in the Europe, they told me that they haven't thought about entering the Indonesian population, entering Indonesian market for the pressure flow. I don't know about the syndrome because I don't have a contact with the SEN. If we have a medical versus surgical in IOP control with the time point, it is a study by Costas and Toposis about several years ago, I think. They compare the we know that in the baseline and then for the medical about 10 a.m. it is quite the same, but then in the different time, as we could see here, mostly with the surgical is quite stable. It is like about 11 to 12, but for the medical, as we could see, it is quite range, have a variety. I think because it is like individual has like specific reaction maybe with the specific medication. The minimum and maximum, as we could see, for the surgical about 11 to 13, but for the medical it's about 11 to 16. For the trabeculectomy, I'm sorry, I will talk about trabeculectomy because it is quite common in our country. We should have a thorough examination like clinical condition, ophthalmology, systemic, and also medical therapy that has been given. And we know, and we have to examine the condition of the conjunctiva, whether there is a scarring or not, or whether this patient has previous surgery or not. Because if the patient has previous surgery, the probability of failure will be higher. And then also the access, the need for antifibrotic agents. In our country, it is quite hard to have a mitomycin C. So some doctors, it is easy to have 5-FU. So we use 5-FU instead. But in my hospital, we could use the mitomycin C. Maybe in the some of bigger hospital, they could access the mitomycin C. And then we have to try to control the IOP preoperatively better if we could have less than 30 millimeter mercury. And then for the doctors who just doing the trabeculectomy, I mean not common do the trabeculectomy, please do the trabeculectomy step by step and try to do that how to perform it well. And then close monitoring post-operatively, because a glaucoma surgery is different with a cataract. For the glaucoma surgery, we will have the wound modulation. Sometimes, although we try to perform it very well, sometimes the result is not as we expected. So we have to monitor the patient closely, and we will see whether the wound modulation is as we hope. Success rate of trabeculectomy in IOP control, as I mentioned, there is a wound modulation, and it will decrease with time. Like trab with antimetabolite, there is several studies that comparing trabeculectomy with antimetabolite and trabeculectomy with antimetabolite. It seems that trabeculectomy with antimetabolite is quite well compared with the trabeculectomy without antimetabolite. As we could see here in the study, in 5 years, they have a success rate about 83%. But for the trabeculectomy without antimetabolite, in 4 years, the success rate has been decreased to 54%. So if we choose trabeculectomy, so maybe we have to use the antimetabolite for the patient. And then we know that several conditions will affect the failure or the success rate for the trabeculectomy. And then the treatment of various type of glaucoma. Is my time still enough, Prof?
Yes. Although I don't know, you might want to finish and then there could be questions if you
yeah,
like.
okay. So
Yeah,
we'll stop here, Prof, because I think if we talk about the medical and surgical, it is very, very quite range of topic, right, Prof?
You can talk for hours and hours.
Yeah,
That's
yeah.
right.
So I think
shall we see who would like to ask some questions? So Virna, you've covered an enormous area, a lot of ground there. I guess you've hit on key points to do with compliance, and that's why we probably tend to use drops that you only have to use once a day to try and, with minimal side effects, to maximize compliance. Judgment of progression, to know when to operate, and then the choice of surgery, really. But yeah, have we got some questions?
We have some questions, bro.
Now I have to find. Oh, good.
In the chat room, bro.
Oh, thank you. So, Dirani, thank you, Virna. In patients with neovascular glaucoma, what's considered to be the most efficient surgical approach?
The question from?
Sorry, I didn't go to the first one. Sorry, first one.
It is in Bahasa, Prof.
Yeah, so, I can't read that. Sorry, that's Iti Damila.
Yeah.
Are you able to?
Yeah, I will translate. So, she asked the tolerance to use acetazolamide, especially in the hospital that only have timolol, acetazolamide, and latanoprost. So there is hospital which only has timolol, acetazolamide, and latanoprost. And latanoprost could not be used in her patient. So she only be able to give the patient timolol and acetazolamide. How long actually we could give acetazolamide? So I think I've seen Prof. Morgan given acetazolamide quite long. But actually I'm not brave enough, Prof, for giving acetazolamide for a long time, because I have seen quite a nasty complication, Prof. One of my patient has blood dyscrasias. So this patient has I only actually give like 2 times a day for acetazolamide, and I only gave him for only about 3 or 4 months. But then the patient has blood dyscrasias, and then a few months later, her wife told me that his husband died. So for acetazolamide, I usually only give the patient maybe on top only about 3 months. More than that, I'm a bit worried. And then sometimes if I have to give more than a month, like about 2 months, sometimes I ask the patient to have a lab examination for the blood test, and also for the renal function. Because the cases that I have, that then I'm very careful in giving acetazolamide for quite long time, Dr. Etty. So sometimes in the case like this, I will ask the patient whether she or he willing to have a early surgery. In my opinion, also in my experience, I could see that patient with early surgery prior the medication sometimes have a good conjunctiva, Prof. And then it is quite a long success rate. I have one patient. The first eye was actually has a primary surgery, but the second eye has a medication for several years, and then later on, I have to do the trabeculectomy in the other eye. And I could see that for the first eye, it is still in the good control of IOP, but the left eye, the failure is about in after 2 years, I think. I mean, it is not failure, but I have to add glaucoma medication to control the IOP. But the other eye, which has a primary surgery, it is well controlled without medication. So maybe we have to decide more. But I know that patients sometimes not eager to have sometimes they will choose the medical treatment first. So Dr. Eti, maybe it is your wise whether you have to explain to the patient the benefit and then the risk to giving the oral medication for sometimes. I think that. Prof. Morgan, do you want to have adding the?
No, in many ways, the drugs that cause least trouble for future surgery are actually timolol and acetazolamide. They have the least effect on the conjunctiva. So if you look at trabeculectomy outcome studies done before prostaglandins came in, they didn't use antimitotics actually, and their outcomes were very, very good. As soon as the prostaglandins came in, two things happened. We tended to do less trabeculectomies, but also the success rates deteriorated, and we started to use a lot more antimitotics. And I suspect the topical carbonic anhydrase inhibitors and alpha-2 agonists are much the same. They tend to cause quite a lot of conjunctival reaction. So in many ways, the hospital that only allows you to use acetazolamide, latanoprost, and timolol, they're probably the most cost-effective drugs. Although, and then probably in many ways, patients who don't tolerate those and are progressing probably should have surgery. But if you took a population health economics sort of cost-benefit ratio, that would probably be the best form of treatment, really. Shall we go on now? We go into another question. We've got lots of questions, actually. I'd like to ask about the role of stem cell therapy in glaucoma. Is stem cell therapy promising for glaucoma patients?
Stem cell therapy. Actually, Prof. Ike has done this study, Prof. Whether Prof. Ike want to answer, I think Prof. Ike is in the
audience.
Yeah.
Ike, please, Prof.
Hi.
Yeah, in my no effect at all. So I don't have any response very well in the stem cell therapy in my patients. So so far, I think the stem cell in my patient is not work very well. So I don't know, Prof. What's your opinion about that? Maybe you heard about in Australia.
Yeah, I haven't seen stem cells used at all, but I've heard much this. Hello, you're in the nice forest. I haven't seen the stem cells used at all, but I've heard similar. I haven't heard of any really good results from them. So I think it's best viewed as an experimental treatment and not kind of mature, possibly. Yeah.
So the stem cell right now is not the choice of therapy, right, Prof? And Prof. Ike also got the same thing like that.
Yeah. Thanks, Ike. Thank you for sharing your experience. That's actually very interesting. Now.
Yeah, it's very interesting, but it's not responding.
That's a shame. I was going to say something similar about you talked about the Rho kinase inhibitors.
Yeah.
In practice, I've used them a little bit. We can get them on a special scheme. But, I've used them on 3 patients. They haven't worked on any of them, and they cause quite a lot of redness as well. So, look, it's only 3 patients.
I see.
Maybe, but I'm not sure.
I don't have experience, Prof, for Rho kinase. Oh, okay.
There's another question. Is there any criteria for patients with primary opening glaucoma trabeculectomy?
Okay, I think it's.
Do you want me to answer that one? Yeah. Short answer is I don't really know. I think that in terms of reducing pressure more, trabeculectomy has the advantage over a Zen stent. So we did quite a large study, over 200 patients with about 270 eyes, followed for 2 years. And the pressure reduction was reasonable with the Zen stent, but it's probably not as good as what you get on average with a trabeculectomy. So if you want a really low pressure, you should probably do a trabeculectomy. Also, we don't know how long the Zen stent will last for. My gut feeling is you probably last about 5 years, is my gut feeling. Now, the problem with the Zen stent is that it's got a very narrow internal bore of only 45 microns. When we use the larger gelatin stent for the phase 1 trial, that had a 120 micron internal bore. And those results were actually we only had them in 23 eyes, but they were all patients who'd had, so that suggested that that type of stent was possibly better than a trabeculectomy. And we followed them now, and they've tended to fail at about 9 years.
Oh.
The ones that have succeeded, so which is not too bad. And remember, that's only a small number, it's only 23, and it's not commercially available, unfortunately. So I think that the real answer for your question is a trabeculectomy will probably get you a lower pressure than a Zen stent, but at the cost of likely more high risk of complications. So that's the trade-off.
Yeah. Thank you.
Next question. In patients with neovascular glaucoma, what's considered the most efficient surgical approach? Virna, you get lots of
yeah, bro. For neovascular glaucoma, I will choose the glaucoma implant surgery actually, because we know that it is quite a lot of scarring, and also the progression of the disease, and the IOP is very, very high. So I usually use the glaucoma implant for the neovascular glaucoma. And same with you, Prof, right?
Yeah, exactly. Yeah, no, very straightforward.
Yeah.
Question is, in cases of young patients such as juvenile glaucoma that come in with at an advanced stage, do you consider a primary tube like a VGI, or would you use mitomycin C while doing the glaucoma drainage device or the VGI?
Okay.
So choice of surgery in juvenile glaucoma at an advanced stage, and would you use mitomycin?
I still prefer to choose a trabeculectomy as a primary surgery. Yeah. I don't think implant for the young people, because we know that we have to evaluate. Implant is not without complication as well. We know. We know that it will cause like endothelial loss, and also sometimes we have a tube erosion. And for the young, although I don't have the patient that I have handled for the juvenile is not as many as an adult, but I think trabeculectomy is still the safer for me. But I don't know for other doctors, because I know that some doctors prefer to have a primary tube for the juvenile glaucoma. But for me, at least, I will choose the trabeculectomy as the first primary surgery for the juvenile glaucoma.
Yeah, I would tend to do the same. So juvenile glaucoma, it really encompasses the ages of probably between 15 and 40. Yeah. So there's a fair age band. If they're really young, like if they're 15 or 16, I would tend to probably go towards using a glaucoma drainage device. But they're quite uncommon. Most of the time they're in their 30s or maybe approaching 40. And so most of the time I would do a trabeculectomy. Although sometimes they fail, there's a certain proportion that will fail, and then I'll just put in a glaucoma drainage device. So really exactly the same answer that you've just given, Virna. Yeah.
Okay, thank you.
Then the last question is, what's your opinion on oral citicoline as an additional treatment in glaucoma management. Now, I'm not familiar with citicoline. Are you? What sort of drug is that?
Citicoline is a neuroprotective agent, Prof. And we have several study about this in patient with open-angle glaucoma, Prof. And then we have maybe sometimes I will share with you with the data. We have a quite good experience with citicoline oral, Prof, but not topical. I know when I've been in the previous conference, they developed the topical citicoline. I think one of the Italian company have that. But for Indonesia, we only have oral citicoline nowadays still. And then when we have the study, I think Prof Iko also has the study. We evaluate prior and after we give the citicoline orally. For my study, I comparing with the 500 milligrams and 1,000 milligram. And Prof Ike, I think the study is comparing with the control, so without citicoline and with citicoline. And then the result is quite. It is like an increase, Prof. At least there is no decrease during the follow-up for the parameters that we use as the comparison. So it is like a stabilized glaucoma progression, I think, Prof. But it is in the condition where the IOP is well controlled. So if the IOP is not well controlled, we know that there is another pathogenesis that cause the progression. I think it's my answer for the oral citicoline, but for the topical, I don't have any experience in it. But I know some factories already produce the topical citicoline. You know, maybe Prof Ike want to share also her study about citicoline.
Yeah, Ike, it'd be interesting to hear your thoughts on citicoline. Thanks very much, Virna.
Yes, Prof.
I think it's similar comment with Dr. Virna. Citicoline has a good protection for the neuron itself, especially for the ganglion cell, as well as for the retina nerve fiber layers. And I have experience with the what you call it is the macula visual field, with the central visual field, and then it will increase the visual field pre and post after we given the medication of the citicoline. So that improving the visual field of the patient itself. So it's very good in the central of the visions of the visual field, Prof. So I did in the 60 patients so I comparing with the control.
Right. It would be very interesting to see. Have you published that data? It'd be very interesting.
Yeah, since I'm very busy by the time, so I haven't published it yet. So I also comparing with the ERG, and then PARG also. This is very interesting study, and then I've the result also is very good. When was it, Dr. Virna? I forget that once. So it should be
2012, Prof.
Yeah, it's a long time ago. So I think I have to. I think we have to review again, and then we have to, mengulang kembali ya, Virna ya.
To repeat the study, maybe, Prof.
Have to repeat again to make sure.
Yeah, that's interesting. Just while you've been talking, I've been looking it up on the internet. It looks like there's quite a few studies with relatively small numbers of patients. It would be fantastic to see a study with a large number.
I think we need the large number of patients, and then to make sure whether it's not a bias thing, because it's very It's 60 people is not enough. We need more. They told me about that because it is a clinical trial.
Yeah.
So 60 people is not enough. They told me that. So that's why I reluctant to publish it.
Yeah. That's, I can't comment. I can comment on memantine. We were involved in a large multi-center trial of memantine about 15 years ago, which went for 5 years and had about 500 or 600 patients. Might have been more actually. But
memantine.
Unfortunately, they did not find that memantine was protective. It had no effect, in fact. But it would be interesting to acetylcholine's one. There's vitamin is
So the number of subjects, it should be more than 100. I think it's like memantine study that Dr. Morgan just did. I think it's about 500 or 600 subjects. That will be a very good study. I think. Yeah.
Well, I think that's a fantastic way to end, isn't it?
Yes, Prof.
Looking at the future, possibly, for some medical treatment.
Yes, Prof.
And Virna, thank you very much for your talk. You covered a lot of ground, and the questions were really excellent questions, actually.
Yes, thank you.
Thank you for everyone who asked the questions. And I'm excited about 1 month's time. We'll have another meeting, so that'll be terrific.
Yes, Prof. We will see you in Jakarta.
Yes, exactly.
Should we have a photograph, Dr. Mita, or?
Yes, doctor, I can do that.
Yeah.
So I invite Prof and doctor to open the camera.
You open the camera, everybody.
Okay.
I'm taking my glasses off.
That's great, Prof. Okay, I will take the pictures from the screen number 1. 1, 2, 3. Don't forget to smile.
Thank you. Thanks very much.
Okay.
There is layer, I think, Prof.
Sorry?
Yes, but I think the video is not opened yet.
One, how many, Dr. Mita? 1 or 2?
Yes. 1 is enough.
Oh, 1. Okay.
Yes.
Thank you, everybody. Thank you, Professor Morgan. Thank you, Jessica. Thank you, Prof.
Thank you, Prof. Morgan.
Oh, that's a pleasure. Thank you. I didn't do anything. Virna and Jessica did everything. So thank you for Virna and Jessica.
Thank you. Thank you.
Nice to see you all.
Nice
Bye.
to see you.